Well, thank you, Professor and Chairman, for introducing me and those kind words, and thank you for coming on Sunday to listen to this talk. You've already heard from Professor Jenna about the management of the movement problems. You also heard from Dr. King the management of exercise, your gait, walking, and so on. What I will focus on is the management of the non-movement problems of Parkinson's, the non-movement problems, and these are very, very important. So first, I want to show you the face. All these people, some of you might know them, Muhammad Ali, for instance, Michael J. Fox, the actor, Billy Connolly is a comedian, Linda Ronstadt, who used to be a rock music singer. All these people have Parkinson's disease. But Parkinson's is very different in these people. So for instance, Muhammad Ali, when he had Parkinson's, he had a lot of tremor. Michael J. Fox doesn't really have tremor, but he suffers with a lot of anxiety. In the case of Linda Ronstadt, she had real problems with pain, a lot of severe pain. And this lady here, her Parkinson's was associated with dribbling of saliva as well as sleep problems. So you can see that Parkinson's is much more than this tremor and the rigidity and the stiffness. I will show you a video now. This is a video of Muhammad Ali opening the Olympics in Atlanta. Look at his hand. And the tremor. So what you see here is his face is not working very well. He has the tremor. And he's very, very slow. So that's the face of Parkinson's that we see. Those of you with Parkinson's here will be familiar with it. But we now know that's just this part, the movement problems. Below it lies the non-movement problems of Parkinson's. And that's what we will talk about. What are these non-movement problems and how can we treat them? We have to remember that Parkinson's is a very complex problem. The condition probably starts here and ends here. This is altogether about 40 years. You have, now we know, a thing called prodromal PD, or prodromal Parkinson's. This is before Parkinson's starts, the movement problems start. People might lose their sense of smell. People might have sleep problems. People might have violent dreams at night, and you can hit your partner at night without realizing it. You might have constipation. You might have severe depression. All of these problems can occur in the prodromal Parkinson's. This is where the diagnosis is made. This is where the doctors make the diagnosis. And then it progresses. And all through this period, there are different non-motor, non-movement problems that occurs till the very late stage. So let's just talk about these a little bit more. Why do we need to talk about these non-movement problems? Here you have gastrointestinal problems. Here you have pain, urinary problems, sleep, fatigue, severe tiredness. Here you have apathy, when you lose interest in things that you like to do. Here you have memory, problems with memory, problems with attention. Here you have problems with depression and anxiety. And here you have problems with breathing sometimes. All of these, as soon as you have these problems, the quality of life goes down. So it's not just treating the tremor, not just treating the stiffness, but also treating the pain, the dribbling of saliva, the problems with depression, the problems with memory. The good thing is, all of this can be treated, but they must be recognized. They are the hidden part of the iceberg. We don't see it. But as doctors, as nurses, as healthcare professionals, and you as patients need to recognize that this is part of Parkinson's. Another example how this is important, this is a bit of data for you, I'm afraid, but it shows that if you have these non-movement problems in dots, they have a very strong correlation with quality of life. The higher the non-movement problems, the worse the quality of life. So therefore, it's very, very important that this is recognized and treated. What happens when we ask our patients, like yourselves? This is a study from the UK where 173 patients were asked to rank what are the 10 most troublesome problems they have. 10. The number one they ranked was fluctuating response to medication. So when you take your tablets, your response fluctuates. For a while you're okay, then you know you need to take another one because the tablet's wearing off. You probably heard that from Professor Jenna. Mood, that's the second problem they have. Dribbling of saliva is the third problem they have. Sleep is the fourth problem they have. Not the tremor, not the rigidity. They're talking about non-movement problem. These are Parkinson's patients telling us. Here you have pain, bowel problems, particularly constipation, urinary problems, having to rush to the toilet regularly, getting up at night to pass urine regularly, falls you've already heard about. And finally, appetite and weight. People might lose their appetite. You may not be able to taste food very well, and your weight might go down. So these are things that really bother our patients most. Not so much, you can see tremor is there, and probably the only motor symptom, that movement symptom among the top 10. Another study, this is from the US, in over 1,000 patients, shows that 90% of patients have problems with handwriting, but also fatigue, excessive severe tiredness, which is not just sleepiness, this is very severe tiredness. But also people have problems with urinary dysfunction, sexual dysfunction, insomnia, anxiety, loss of interest, as I said, dribbling of saliva. All of this are top symptoms in our people with Parkinson's. Not so much just the movement. So that is the importance of this non-movement, or what we call the non-motor problems of Parkinson's. In spite of this, the problem is our doctors, our healthcare professionals still continue to neglect, partly because they don't have time, and secondly because some people just think Parkinson is just a motor problem. No, it's the movement problem. But as you can see, what our patients, you are telling us, is much more than that. Now, why is it still neglected? The neglect occurs because we're not using regular tools, regular scales, regular questionnaires. If you rely on, the doctor relies on his memory to treat somebody with Parkinson's, they will always focus on movement. Here's an example. This is a study we did in Europe. We looked at over 100 patients, and we asked them using a questionnaire whether any of these problems have been discussed with the doctors. Sleep problems, depression, anxiety, hallucination, when you see things which are not there, apathy, losing attention and memory problems, sexual dysfunction, urinary, and problems with dribbling of saliva and swallowing. You can see in 43% of consultation, the problem with swallowing and dribbling was never mentioned. In over 45%, there was no discussion on sleep problems. In over 50%, no discussion about hallucinations, which was a problem. So you can see how, unless we recognize these non-movement problems, we will not discuss them. And if you don't discuss it, you're not going to have treatment for them. And that takes us to another problem, is why? Why is it occurring? This is a study very recently published. We asked our patients, why do you think people don't discuss this non-movement problems. What are the barriers? What's stopping this issue? Well, we can see that some people said uncertainty whether the symptom is part of Parkinson's. Some people didn't know that pain or problems with depression or anxiety could be part of Parkinson's. Others thought it's not serious, we don't need to bother about it, it's not serious. Others thought it's just part of life, just accept it. Some others thought that you can do self-help strategies, you can go and do your own things. But actually what it's telling us, these beliefs stop the treatment, the symptoms from being properly treated. So these are the barriers that we have. Now how can we overcome this barrier? Well, one simple way we use in the UK and many parts of the world now is this questionnaire. It's a simple questionnaire. It's filled by the patients and the carers. It's been translated to Chinese, and I heard yesterday there's a Hong Kong translation as well. How do you use it? Well, you can download it from the net. It's in several societies will have it, and it asks you 30 questions about these non-movement problems. Have you had dribbling of saliva? Yes or no? Have you had problems with sleep? Yes or no? Have you felt depressed at times? Yes and no. Very simple. It takes 2 minutes to complete. And how we do it? Here's an example. This is a patient in our clinic. She comes and sits. We give her the questionnaire. She's completing the questionnaire. These are the 30 questions. Yes, no, yes, no, yes, no. And then she gives it to the doctor. 6, 7. The doctor then counts it. There I am. She scored 7 out of 30. So she has 7 non-movement problems. And then we will discuss a case with myself.
How long have you had Parkinson's?
Let's stop it there.
I was diagnosed.
It's a very simple way. Therefore, you take it off, give it to the doctor, and then you have a discussion about this non-movement problem. If you do this, then these symptoms, like in that study, will not be missed. Moving on, why is it so important? So here's a patient who's completed this questionnaire. The patient is not treated first time, come to the doctor for the first time. He's got very mild motor disease, just a little bit of tremor on one side and stiffness, that's it. And when he completes the questionnaire, he says he's having a bit of dribbling of saliva, he has a little bit of urgency to go to the toilet, he has some pain, he feels a bit lightheaded and dizzy when he's standing, and occasionally he has loss of interest in things. Just 5 symptoms. So his score is 5. Okay? Same day, we have another patient, untreated like this patient, same mild motor disease, little bit of tremor, nothing else. But when this patient completes the questionnaire, his score is 19, 1-9. He has problems with sleep. All these questions are related to sleep. He has vivid dreams, he is moving at sleep night, and he has some falls. And then he has constipation, he has problems with swallowing, etc. So this patient will need very different treatment to that patient, but they both have Parkinson's. Why? Because their non-movement problem profile of this patient is very different to this patient. And you don't need to do sophisticated tests, you don't need to do fancy blood tests or scans. Simple questionnaire takes 2 minutes to do in the clinic. In the UK, this has been recognized. So the NICE, which gives our guidelines, now has non-motor symptoms or non-movement problems as an integral part of the management. So every patient in the UK goes to the clinic must have motor and non-movement problems measured by using something like that questionnaire. And what we do is all patients complete this at least once a year, and they have a motor assessment by looking at one side of the body, 2 sides. Again, this takes literally, doctors do this or nurses do this. This takes literally 1 to 2 minutes. This takes 2 or 3 minutes to complete by yourselves. And then you have a motor assessment, a non-motor assessment. And based on the number of questions you answer, you can grade from very mild non-movement problem to very severe. And that will trigger treatment. How do we now manage these problems? So let's talk a little bit about it. It's impossible to talk about all 30 different non-movement problems in this lecture, but I will just briefly touch upon some key ones. Depression and anxiety. About 1/3 of the people will have this problem with depression and anxiety. Here is a patient who has very severe anxiety and pain, and you'll see her example. Getting pain, is it?
Yes, I have pain down my back, all down here.
Okay, why don't you take the rest of the medication now? Do you feel quite tense and anxious?
Yes, all stiff. I can't, I'm just not kicked in at all.
Okay, okay.
Well done.
That's it, very well done. You'll see it slowly will settle down now. Okay, so this patient has a wearing off. So she's taken her last levodopa about 2 hours back, and the drug's worn off. But as you see, when she's wearing off, she's not worried about her tremor or stiffness, but she's very anxious and she has severe pain. And how do you get rid of that? Giving her another liquid levodopa. When she drank that, within 15 minutes, she was absolutely fine. No pain, no depression, no anxiety. So this is fluctuating. Depression and anxiety, therefore, could be related to the motor symptoms of Parkinson's. Very important that the doctor or the nurse or yourself recognize that this is related to how the levodopa dose fluctuates. And there are many trials. I'm sorry, you may not be able to read this very well. If this occurs if somebody feels regular depression, regular anxiety, then treatment is required, and probably there are two best drugs to use. One is called nortriptyline, and the other one is called citalopram. But the important thing to remember is depression and anxiety are very, very common in Parkinson's, and they can fluctuate. Somebody does not necessarily need to be anxious or depressed all the time in Parkinson's. There are other treatments. Rasagiline could be used, some claim. Cognitive behavioral therapy can be used. This is training of the mood. Can be done by experienced psychologists. So that is another area where depression and anxiety can be managed. Next, move to hallucinations. Hallucination means seeing things that are not there. In Parkinson's, it's almost always visual. I don't know whether you've experienced this. And there are various types. You can have minor illusions, just see a shadow of somebody. Then you can have passage. You see some animals moving. Okay? You have illusions. You see a cat, but you see the cat like a leaf. Or you can see pictures of things not very clear. And you can have presence. Presence means you feel somebody's there with you. Or you can even have double vision. All of this falls under the hallucination spectrum. Then you have hallucination with insight and without insight. With insight is you know that this is a hallucination. Without insight is when your partner or somebody tells you, actually I think you're seeing things. And then finally you have delusions. Delusions means you have a belief that's not there at all, it's not true, but you're not aware of it. You believe it firmly, but your partner or your other relatives or family is telling you actually that's not true. So you can see the whole range of things can occur with this hallucination type problems, and they can be treated, and treatment is very important. But one of the most important treatment is reduction of anti-Parkinson medication. Hallucinations in Parkinson's occur if you have infection. If you get a urinary infection, chest infection, often people start having hallucination. The second is due to the drugs. And when you have hallucination, usually you have to first reduce anticholinergic drugs if people are on it. Then amantadine, another drug that can cause this. then drugs such as selegiline and dopamine agonists. So the doctor or the nurse will then slowly reduce this drug because that's leading to causing the hallucination. If it still persists, then you have to use drugs, and you can use cholinesterase inhibitors like rivastigmine, you can use donepezil, and also you can use another drug called quetiapine or clozapine. Clozapine means you have to do regular blood tests. And more recently, there's a trial now been published, several trials, actually 3 trials, another drug called pimavanserin, which I'm not sure whether it's available here. Pimavanserin seems to have very good effect on managing hallucinations in Parkinson's disease. What about dementia? That's another problem in Parkinson's, cognitive impairment. This can occur in many patients with advanced Parkinson's. What are the symptoms? People might have difficulty with planning. If you want to plan what are you going to do today, you have difficulty. Difficulty with concentration, difficulty with words, difficulty with names. Can't remember names properly, difficulty with calculation. And this can also be caused by some medications. Some type of medication can make these symptoms worse, particularly drugs which have anticholinergic effect. And what we are here looking at is 2 main drugs, rivastigmine, which can be given as a tablet or a patch, skin patch, or donepezil also has been shown to be some effect, and there's another drug called memantine with borderline effect. So the mainstay of the cognitive side is support, understanding, and cholinesterase inhibitors such as rivastigmine and donepezil. But it must be remembered that memory problems are very common in normal people as well. As we get older, we all have memory issues. It's called benign forgetfulness. So we have to balance the two together, but memory problem is a major issue in Parkinson's, and if this is an issue, flag it up because that needs management. There's a study from here, from China, about this Dihuang EZ with donepezil, and the combination of these two appear to help, according to this study, people with memory issues. This is a small study that's been published in 30 patients, but I put that up because it's from local area and might be of interest to yourselves. And now we come to sleep. It's surprising how we as Parkinson's doctors often don't talk about sleep in Parkinson's. Parkinson patients need control of their symptom not just at day, but also at night. More than 50% patients wake up at least at night due to problems of Parkinson's. 72% of patients have difficulty falling asleep. 2 out of 3 patients feel their nighttime symptoms are not controlled. 78% say that if they sleep badly, it affects their daytime. And that's common sense. So this is really, really important, sleep. But more importantly is this study just been published. People who have bad, insufficient sleep can have problems with neuroendocrinal status, and that can lead to diabetes. We know poor sleep has been now linked to diabetes, has been linked to cardiovascular problems, has been linked to immune function. You become more susceptible to infection, and it can cause cognitive problems. Poor short-term memory, poor working memory, worse executive function, variability in attention. You become more forgetful. All of this can happen if your sleep is not good. Yet, most of the treatment that we offer in Parkinson's focus on daytime. After about 8 o'clock at night, we forget things. But that's not true. That's not real. It needs to be managed, and therefore management of Parkinson's must go through management of sleep. Because sleep is very, very important, as you can see. And if you do not sleep properly, flag it up to your doctor, because it really needs management. Otherwise, these problems will start. How can we manage this? The excessive daytime sleepiness. Here's a picture of one of my patients. He has fallen asleep on his plate of food. His sudden onset of sleep is very, 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 very problematic. This is a particular problem if you're driving. If you want to drive, it's not a good idea. particularly to drive alone. If you have Parkinson's, if you're driving, you must have somebody in the car with you, because otherwise there might be a serious problem with traffic accidents. And this is not new. It was published in 1999. People who take pramipexole and ropinirole are particularly at risk. They can end up with traffic accidents because they might fall asleep when they're driving. And this is because now we know that many people with Parkinson's have a thing which looks like narcolepsy. Narcolepsy is a condition when you fall asleep suddenly. And some people with Parkinson's have exactly the same. And in these patients, if you have these sudden sleep attacks, you must mention it to the doctors, because here we should avoid pramipexole and ropinirole, two dopamine agonists. We should avoid any form of sedative drugs, and caffeine might be required, caffeine tablets, not just coffee. And this is again shown here. These are some other studies. This is another drug called pyridoxal, which has been studied for excessive daytime sleepiness. I will talk about sleep apnea in a minute. And there's another drug called sodium oxybate. Also helps this problem, but has to be prescribed by specific physicians, because sodium oxybate can cause addiction and can cause memory problems. So, but it is a drug that is there for daytime sleepiness, particularly those narcoleptic problems. Now, I mentioned sleep apnea. There's another thing to remember, that many people might feel severe sleepiness during the day. That's because at night they're having sleep apnea. Sleep apnea means, here you see every time the line's dipping means the oxygen is dropping. We keep ourselves oxygenated when we are sleeping by our breathing, but if you suddenly stop your breathing for a few seconds, and this happens typically in people who snore very loudly at night, and the oxygen drops and people have this subconscious waking. And every time that's happening, the person is waking up. And that can be treated by using a mask. That completely stops this problem. So if you have very severe sleepiness during the day, also mentioning this is very important, because a test like that can give a diagnosis of sleep apnea, which can be very, very easily treated. I will move on because of the sake of time. The other problem is REM behavior disorder. Let's have a look at what that looks like. Look at this patient. The patient's sleeping in a sleep laboratory. Okay? This patient is asleep. But what happens? He had a violent dream. He dreamt somebody's attacked him and he's hitting out against that person. This is called REM behavior disorder. It's very, very common in Parkinson's. Dreams are acted out, screaming, kicking, punching, thrashing. It can cause injuries. Again, it's a problem usually for the bed partner, because the patient is asleep. And it must be recognized, because it can cause severe problem. And I'll show you another video. Here is another patient of mine. This is in a sleep lab. The patient is there asleep with the wife. Now he's shouting, okay, and he's kicking. He's waking up his wife, and now he's kicking this person who's attacking him. And then he screams. Okay? Another view. And what that causes is...
The following clip shows a gentleman in bed.
Has left.
The video was taken during polysomnography.
Okay. So
in the clip, we observe the gentleman's abnormal body movements during deep REM sleep.
So, important there for REM behavior disorder, as you can see, it affects the partners, must be flagged up to the doctors. Melatonin or clonazepam are probably the two best drugs to use. There are some trials going. There's a drug called nilotonserine, which is being trialed. And other drugs have been tried, for instance, gabapentin, cholinesterase inhibitors, and also cannabinoids. These are another groups of drugs. They're all tried, but probably the two best drugs to use are clonazepam and melatonin, which stops this problem, and a very important problem for sleep. Another important thing for sleep is that amongst all the Parkinson's drugs we have, retigatin patch has a very good effect on sleep in Parkinson's disease. And you will not be able to read this, but here you can see retigatin patch can help some sleep and fatigue. It can reduce the number of times you wake up at night, number of times you go to pass urine at night. It can help with restless leg syndrome. And it can help with cramps and akinesia, difficulty turning in bed at night. It can help with all of that. So its transdermal patch of retigatin is a very good drug for all these different nighttime problems of Parkinson's. Another problem, let's now move to the GI tract and we'll finish there. Dribbling of saliva, real problem in many patients. Up to 50% of Parkinson's have this dribbling. But it's not because you're producing excessive saliva. It's because people are not swallowing properly. It's caused by saliva pooling in the mouth and decreased mouth movements and swallowing. So the first thing to do is to keep your head up and help swallowing. And that can be sometimes helped by what we use is a swallow timer. A little timer, like a tick, which tells you now you should take a swallow. And that helps the saliva to go down and not come out. But otherwise, you can use atropine. Atropine, which is used for eyes, can be put in the mouth with a little bit of either water or sometimes even with a bit of ice. And in some cases where there's very severe swallowing problem, you might have to have botulinum Botox injections into the parotid glands and submandibular glands. But this has to be done by a very specialist route. So atropine and botulinum toxin, remember to swallow in time and keep yourself well hydrated. Lots of fluid, very important. Another problem in Parkinson is hyposmia. Many people with Parkinson's have difficulty with sense of smell. And this is an important problem because if you have this, you must notify your doctor or your nurse, because if you have bad problems with sense of smell, you may not be able to smell gas and you might set fire. In such situation, gas, what we would suggest is replacing the gas appliances with electric fires is much better. Also, some reminders about food so that you can smell food properly. So there are some simple tics that you can do if you have reduced sense of smell. And this is something, again, we need to remember in terms of our management. Orthostatic hypotension means when you stand, the blood pressure falls and people get very dizzy. This is common in Parkinson's, 1/3. The key symptom is you feel lightheaded when standing up, or some people might even faint. How do we manage this? Number one is fluids. You must make sure you're drinking at least 2 to 2.5 liters a day, just water or other liquids, and keep enough salt. It's very important that the diet contains enough salt. In addition, you can do physical maneuvers like leg crossing when you're standing, periodically crossing your leg, or squatting, or even bending forward like this, or tiptoeing, walking on tiptoes, just on your toes. That tightens the calf muscles and sends blood up the veins into the brain. Simple measures, but also drugs are available. Fludrocortisone is commonly used, but also there are drugs like midodrine, more recently L-DOPS can be used. There's a drug called octreotide, which is an injection. Some people have a meal and they feel very tired after that. That is because all the blood goes to the stomach and the splanchnic circulation. And people feel very dizzy and tired after the meal. They feel very sleepy and the drugs don't work. In this situation, octreotide injection might be quite useful. I will finish with bladder and constipation. So bladder, passing urine, difficulty with passing urine, urgency, incontinence, getting up at night to pass urine, very important problems. But in most, bladder is usually overactive, and usually getting up at night to pass urine or frequently passing urine is an issue. Here, the main treatment option are anticholinergic drugs such as oxybutynin, or more recently there's a trial of a drug called solifenacin. But people are also looking at stimulation of certain nerves which supplies the bladder, called TENS, TTNS, transcutaneous tibial nerve stimulation, and there are some new trials that are on. But very important that you train the bladder. It's also worth remembering that in some situations, doctors might even talk about deep brain stimulation, which has been shown to have a good effect on urinary function. I'm not suggesting anybody with bladder should always have deep brain stimulation, no. But DBS can help with bladder symptoms of Parkinson's, as can indeed some dopamine drugs. Apomorphine injection, rotigotine patch I just mentioned, as well as levodopa infusion. All of these drugs can help with bladder problems, but they work in the dopamine D1 receptor, which can help with these bladder issues in Parkinson. I'll skip over that, but the other thing to remember is the stomach. In Parkinson's, the stomach is very... Have we got time-wise? Are we okay?
Another 2 minutes.
Okay. We have this stomach with all the tablets might pool in it because the stomach is not emptying properly. And here is an example what happens, that your tablets that you've taken in the 9 o'clock at night, 7 o'clock in the morning, 7 o'clock in the morning are all sitting in the large bowel. And these tablets are going to pass out undigested in your feces, in your stool. So as a result, you're not absorbing anything from the stomach. And this happens very commonly in Parkinson's. And this is also associated with reduced bacteria in the gut. It's called microbiota. So to help that, some people are now considering transplant of feces. But more importantly, you must rule out the issue of constipation. Here you have two types of constipation. These patients have problems with the bowel not moving, and here you have obstruction. And to help that, what do we do? Constipation. Lifestyle, you need exercise, lots of fiber and lots of fluid, about 2 liters a day. You need softening of the stool. An osmotic laxative can be used. In some serious cases, you might need enemas as well. And together, these things usually work. And the other thing that has really become trendy is that probiotics might help constipations. And the constipation. Probiotics increase the bacteria in the gut. And by doing that, at least one study here from Italy showed that there was improved constipation. For the sake of time, I'll just move to, very quickly, I'll skip over these. I will just end with pain. Pain is a real problem in Parkinson's. And there are many different types of pain in Parkinson's. So you can have pain due to fluctuation. When the drug wears off, you can pain. Dusty saw in the video. Other people have deep pain inside their body. Other people have pain at night. Other people have pain in their mouth, burning mouth syndrome. Pain can be treated, therefore, by two different methods. One, if you have deep pain, this drug, Targinact, is very useful. And if you have fluctuation pain, again, rotigotine patch or levodopa even, particularly liquid levodopa, can be very useful. And there is another type of pain called unexplained lower limb pain. And I will finish with this video. This is Mr. Chris Garrett. Mr. Garrett, just describe the pain that you've been just telling me about a little bit.
Okay, Professor, it's pretty consistent in the left leg, which is the leg that shakes.
Right.
And most of the time it simply hurts, a dull pain, which is exacerbated by long hours of inactivity, such as sleep. So that when I actually...
I won't go into, it's a long video, but essentially what this patient is describing, a severe pain occurring in the lower bowel and the upper leg. And this occurs mostly in men, in moderate to advanced Parkinson's, and in the upper aspect of the lower limb. It is unrelated to non-motor fluctuations, and often the treatment for this is opiate drugs like Targinact or Tramadol or drugs such as that, but must be recognized, this particular type of pain. There are trials. This is a trial of retigatin patch and pain, suggesting it can work, and this is the trial of Targinact, and you can see that in comparison to placebo, the Targinact works really well in Parkinson's associated pain. So, to end, I think by this time you're probably experiencing a lot of fatigue. Fatigue is another really important problem in Parkinson's. Here you see in this study 50% of patients had fatigue after onset, 50% even before the onset of Parkinson's. Fatigue is very important to treat, and the most evidence-based now is rasagiline, along with modafinil and methylphenidate. These are the three drugs that are probably the best drug for using fatigue, but also along with that, exercise and caffeine would be of use. So I'd like to end by saying that this is a whole range of non-movement problems of Parkinson's. As you can see, it's impossible to cover in this period. You can have problems in the brain department, particularly sleep, memory, and depression, anxiety, pain. You can have bowel problems we talked about. You can have bladder problems, and you can also have intestinal problems. The important thing is recognition. If you recognize, all of these symptoms can be treated. None of them are untreated, can be left untreated. But the important thing is recognition by yourself and by the doctors, by using tools, and only then we'll be able to absolutely perfectly treat this, the hidden face of Parkinson's, and that's what we call the hidden face. And I would like to end with this picture. The reason why we put up this picture is you see this lovely moon and sky and the river, but hidden under there are the houses. And that's the non-movement problem. And we need to light this up, so everybody can see it. Thank you for attention.
Thank you, Professor Chowdhury. 咁第一個問題咧，佢將會作答咧就係問睇緊電視嗰時做運動得唔得？同埋咧第二個問題就係而家喺網上啊嗰啲睇嗰啲運動咧，教人做啲運動咧係有冇幫助嘅
？This one?
Yeah.
Okay. Okay, thank you. So the first question is asking about dual task, and they wanted to know, is it a good idea to combine exercising at home with TV watching sometimes? And yeah, that's definitely a good idea, because then you can get the exercise done. You just have to know it's not, you probably won't be working on your balance, like I talked about the different types of exercise. But yeah, that's definitely a good idea. And someone wanted to know if there's free videos on YouTube or the OHSU website to watch. And there is a foundation in Portland called the Brian Grant Foundation. And they have a website. Brian Grant is a basketball player. He played for our professional basketball team. And he was diagnosed when he was 36. So his area that the foundation focuses on is exercise. And they have videos and information on the website that you can look up. I also had someone asked me a question in the back. Should I answer it now? He asked me to address it.
Okay.
Okay. Someone in the back asked me, for newly diagnosed, he's only had Parkinson's 1 year, and wants to know more about the neuroprotection. And to address that, I would say, I mentioned that the way it's neuroprotective is to increase a growth factor in your brain. And in order to achieve that, you have to exercise very, very hard, much more than just going out for a walk. So you have to push yourself a bit beyond what's comfortable. And that's based on really the animal studies, and they looked at animals on treadmills. So it's something you have to go a bit beyond the intensity of regular exercise.
Okay, thank you. There's another question, probably both for you and Professor. the question is, what should a Parkinson patient do when he or she has fatigue problem to continue exercise or not? 個問題咧就係、如果柏金遜病人覺得好攰嘅時候咧，有 fatigue 嘅時候咧，是否係需要繼續做嗰個運動咧？
Okay, that's a good question. I would say the reason to stop exercising would be if you feel like you're going to lose your balance or fall or pass out, then it's not good to keep going. But we've found in then other populations that have fatigue, like multiple sclerosis, and who are fatigued all the time, it's not harmful to continue exercising. So in that regard, I would say continue exercising if you can, unless it seems dangerous to you. If you're so fatigued, you're going to fall, lose your balance.
Yeah, I totally agree with Dr. King. So fatigue is, as I showed in my last slide, very, very important problem with Parkinson's. First thing is to make sure that the doctor or yourself don't mistake fatigue as sleepiness. They're two different things. Way to find that out is if you have fatigue, if you have a short sleep, when you wake after that, you will not feel fresh. If you have sleepiness, if you have a short period of sleep, after that you feel fresh. So refreshment after sleep means somnolence. No refreshment after sleep means you really got fatigue. That's the first thing to remember. Exercise, as Dr. King says, is good. It's been shown to be of benefit, but graded exercise, whatever suits your body and your lifestyle. And then you can have medications. There is evidence that drugs such as rasagiline or methylphenidate can help with fatigue, even another drug called amantadine. And finally, even levodopa at big doses can help fatigue. So again, it's worth discussing it with the doctor if the fatigue continues to be a problem.
OK， 另一個問題咧就係問是否有口部運動可以幫助改善流口水嘅問題。Probably a question for both of you. The question is whether any exercise can improve the saliva problems in Parkinson's patient.
Yeah. Exercise, general body exercise, probably there's limited evidence about saliva problem, but you see, the reason why you get saliva problems in Parkinson's or dribbling is because people don't swallow. Normally, we're not dribbling because saliva pools in our mouth and we swallow it. That's a normal mechanism. So any exercise that makes your throat and voice, this area stronger is a good idea. But more importantly, it's very important to make sure that the swallow occurs on a regular basis, that you're swallowing on a regular basis. You have to have something to remind you to do that. If you don't swallow on a regular basis, the saliva is going to pool in the mouth and it's going to start dribbling. That's why people dribble in Parkinson's. So important thing is any exercise that can strengthen your swallow muscles is a good idea.
OK， 第二個問題，就係咧問咧，假如行咗6000步一日夠唔夠咧？打羽毛球啊、乒乓波啊，係咪可以幫助咧？第三問題咧就係食cinnamon， 會唔會？因為運動之後咧而減低咗嗰個效用嘅，咁咧同埋咧就應該係同嗰個運動嘅時間係點樣聯繫咧？答咗呢3題先嚇，我將佢譯做英文。The first question is probably for Laurie. I have been having 6,000 steps walking every day. Should I have more exercise?
That's pretty good. 6,000 is about average for people. It's good to have a goal. I think it's between 6,000 and 10,000 is a reasonable goal. It doesn't account for how intense your exercise. It's more sort of activity and not exercise. So on top of that, you have to do some other things. But 6,000 is a reasonable goal just for your daily activity.
Okay, follow up that. He also playing badminton, ping pong. Is it enough?
That's good. Badminton and ping pong are really good exercises for your balance. So if you think back to that chart I showed you, those are the things you should do a couple times a week for 20, 30 minutes. Those are good. But those are good because you go in different directions. You go backwards. It challenges your balance.
Okay. Just a question for Ray. The length of effectiveness of Cinemet will be shortening after exercising. How do I decide the length of time in exercising? Will exercise reduce the effectiveness of Cinemet?
I don't think so. I think exercise, if anything, will promote. I think Laurie showed this as well. Exercise actually has a beneficial effect within limits on the dopamine that has been shown in scan studies. So it should not really have a bad effect on your Cinemet duration. I don't think so. You can feel more tired after exercise. That's normal. Everybody would have it. So I don't think there would be an effect on shortening a Cinemet dose.
I would agree, yeah.
Okay. Another question for Ray. How to deal with sleepiness during the daytime? I translate in Chinese first. 日頭個頭眼瞓嗰時，有咩辦法可以幫助呢？
So again, it's a very, very important question that's been asked. So daytime sleepiness is very common, Parkinson's, but first thing is to find out what's causing it. It can be caused by bad sleep at night. It can be caused by certain medications that the person is taking, and it can be caused by sleep apnea. Or the clue to sleep apnea is if you snore very badly at night. So these are the three things that you need to consider. So the doctor will first look at the different drugs you're taking. Some of the dopamine drugs like dopamine agonists such as pramipexole or ropinirole can make you feel very sleepy. If that's the case, then that needs to be reduced. Second, people will need to look at your sleep quality, and if you're getting sleep apnea, which is breathing problems at night, that will need to be treated by a mask or CPAP. And thirdly, if the condition still persists, you can use some drugs. For instance, modafinil is a drug that can be used to improve sleepiness during the day.
Okay. A question for Laurie. You mentioned the therapy sometimes mention when they walk to count 1, 2, 1, 2. What's the reason behind that? 個問題就係治療師有時提議步行嘅時候咧做1、2、1、2，有咩原因？係咪真係有效嘅？尤其是喺especially when facing attack, is it really helpful to count 1, 2, 1, 2?
Okay, yeah, that's considered an external cue. So some people use a metronome, some people use what he said, 1, 2. It's a way to pace because what happens with Parkinson's is you sort of lose the strong ability to pace yourself internally. So it can help to have external cues. A light, like I showed you the tape on the floor, it's a version of the same type of cueing, so it can help to train you to be going faster.
Okay. One question for Ray. I talk in Chinese first. 請教問一個同膀胱有關嘅問題，就係如果啲小便清唔去嘅時候咧，是否會引致腎嘅問題？ The question is, when the bladder emptying is not complete, could it induce a kidney problem?
Yes, good question. So incomplete emptying of bladder, again, not very common but can happen in Parkinson's. And yes, residual urine, if urine is there for is staying in the bladder and is not coming out, can lead to urinary tract infection, which can spread upwards and cause kidney problems. So yes, this is something very important. If you suspect that, you should discuss that with your doctor, and you may need to have some specific tests to measure the amount of urine in your bladder and then have that treated. So you might need to see a urologist for that.
I think the question has been answered, but apparently there's some misunderstanding by the public. Probably you re-emphasize this exercise reduce the effectiveness of Cinemet or reduce the duration.
I think the questions come back. No, I don't think you need to use more Cinemet if you're having exercise. If anything, if you think that the exercise, Dr. King Laurie said, needs to be graded according to your own body, if you think it's completely exhausting yourself by exercise, then it's probably best to do a little less than that, but you don't need more cinnamon for exercise.
Okay. That's important. No, sometimes 有時我哋即係有啲嘢啊，聽見好似似是如非啦。專家解釋過俾你聽，唔使驚嚇，即係唔好怕，因為做運動啊、食多啲藥啊咁樣樣嚇，完全唔需要嘅。另外一個問題攞呢個啦，亦都一啲好奇怪嘅問題，就係柏金遜症同 melanoma 中文係一種皮膚嘅癌症有冇關係 ？Is there any correlationship between the risk of melanoma and Parkinson's disease?
Yeah, I mean, it's been explored. A lot of studies have been done. Melanoma is produced by melanin containing medicines, and of course, all the drugs used in Parkinson's are dopaminergic. So theoretically, there's a link, but to be honest, the studies have not shown anything conclusive. Only if you have a melanoma that's growing in size, then people would recommend that once a year or perhaps every 6 months you should have that checked by a dermatologist. Otherwise, there's no problem.
都聽明啦嚇，即係仲未有研究肯定話佢哋係一定有關係嘅嚇。OK，I Chinese first，OK。呢個問題咧就話患者好難起步，好普遍啦嚇。喺街嗰度咧就好難畫咗條線嚟提示嗰啲佢喺度喐動啦。咁同埋咧，當起動咗嘅時候咧，就好難停止。咁點樣去幫助佢哋咧？Okay, the first question is, sometimes the PD patients is difficult to initiate, and once they walk, they may not be able to stop fascinating gait type of thing. And when they're walking on the street, you cannot put some lines on the street. How could you help this situation?
So this is a question, this is what people work on in physical therapy. So there's elements they can work on to help with the initiation, to get started moving. It's the anticipation of moving. You work on planning. And you can work on the lines on the floor are typically used to train in the early stages. So you're training for bigger steps, you're training postural reactions. And then you take them away as you are able to do it better. People that are falling at home use lines on their floors just for safety, but yeah, it's not going to help you. You have to train for that event and hope that it works in the moment when you have to catch your balance.
Okay, this question for Ray. Talk in Chinese first. 咁跟住個問題咧就係問，假如好僵硬嘅時候咧，食嘢係好困難，有咩辦法可以幫助 ？When the PD patients are very rigid and have difficulty in swallowing, how could we help them?
Again, swallowing problem very important, because if you don't swallow properly, as I said, you can dribble saliva, but also there's a link with aspiration pneumonia. You can have the swallow going into your chest, and that can cause infection. And again, aspiration pneumonia is very common in Parkinson's. If you're very stiff, and usually that means your swallow muscles are also stiff, they're also muscles. And the treatment there is really something to help with the stiffness. So it could be either taking levodopa, liquid levodopa, or other forms of treatment, whatever there is that you're taking, is to improve that. And discuss that. If you're still getting stiffness, means you're in off state, and that can be associated with swallowing problems, to treat the off period. That can be done with either taking some liquid levodopa, as I showed you in the video, or you can have injections of apomorphine, or you can have the rotigotine patch. So those things will help the off. And with the swallow, again, is improving your posture, swallowing properly on a regular basis and not making sure that the saliva is not pooling in the mouth. That would help. So it's a mixture of strategies that you need to take. Finally, the posture of the head. If the head goes like this, you have more swallowing issues and more dribbling. So the head posture is very important to keep and maintain, and that's where again our therapy colleagues might be able to help.
OK， 所以有時就吞咽嘅問題，我都揾演治療師做個吞咽嘅特別嘅評估啊，或者係 X 光嗰啲特別嘅檢查嘅嚇。咁所以如果有問題嘅時咧，就同醫生講，咁啊去揾啲治療師幫手。OK，I think time is very limited. Just one more questions and then we finish. 因為時間關係，其實有第啲問題同後嗰啲其他問嘅相關都係差唔多噶啦。咁所以我而家就再揀多一兩個問題咧，就可以完結我哋呢個環節㗎啦。因為下晝仲有另外一場嘅講座。咁咧第一個問題咧咁咧就俾Ray Professor Chowdhuri answer。嗰個問咧就係非典型柏金遜 MSA 有沒有呢方面嘅新嘅治療方法？你講嘅 any advancement in the management of multi-system atrophy？
Yes, it's very difficult to answer in one minute. Multiple system atrophy is a condition similar to Parkinson's, but a little bit more faster. It depends on what symptoms. Multiple system atrophy patients have problems with balance, they might have problems with blood pressure control, urinary symptoms, swallowing. So there are developments in all these areas which we've mentioned, but there's no specific any other treatment that I can say, oh, this is the best treatment for MSA at the moment. But overall, management is the same as the management in Parkinson's non-movement problems.
OK， 其中一個問題咧就話，即係早嘅膝頭哥痛啊咁樣，咁呢個其實係好多時候都未必關於柏金遜症嘅，咁一定係你要醫生嗰度做評估，究竟係咪你膝頭哥本身有事啊？呢個後來我哋講過啲柏金遜嘅痛症啊咁樣，所以呢個題目我覺得都唔需要答，因為呢度個資料都唔夠，唔能夠做任何評估。反而想問一條咧，又係好難答嘅問題。Another $10 million questions for Laurie. What is the best exercise for Parkinson's disease patients? 最好嘅運動係邊一種咧？
I think the simple answer would be something you like doing. There's not a specific exercise. There's ideas you can incorporate into any exercise you do. So if you are someone who just walks, you can incorporate larger arm swings and focusing on bigger steps and increase the time that you're going to spend walking. So really just start doing anything you like, that you feel like you'll stick with. There is not one exercise, though, that's specifically will help better than another one.
OK， 好多謝兩位教授咁加入咗好精彩嘅演講由從好遠嘅地方英國啊美國嚟，咁我都知道仲有好多問題大家想問嘅，但係因為時間嘅問題，咁咧就大家都要食晏嘅啦，咁同埋晏晝亦都好多精彩嘅演講，咁所以我哋都要停咗呢個發明嘅問題嘅時間啦，咁我哋一齊同我嚟多謝兩位教授。Thank you very much.
Thank you.
For the excellent presentation and question times. Thank you.